We have a special offer for our Munch Bunch listeners. To book a virtual consult with Megan, she's offering a discount of $25 off. Just email her, Megan, at nwmyofunctionaltherapy.com or through her website, www.orofacial-myology.com. To book a virtual consult with Kimmy for the $25 off, email her mouthmusclememory@outlook.com or through the website www.mouthmusclememory.com. Now on to the episode.
Hello, everyone, and welcome back to the Munch Bunch podcast. You've got myself, Megan Benoit, and my fabulous co-host, Kimmy Nishimoto, myofunctional therapists by day, party animals by night. And we are so excited to introduce our friend, Glennine Varga. Glenny's got a really extensive background in dentistry, in airway, in her own journey. We are going to have to do a whole separate story about that. But today, Glenny's going to talk with us about sleep studies, and in particular, the at-home WatchPat sleep study. That's one that I have done. It's one that we think is really great for patients at home. She'll tell you everything and beyond why. But we're so excited to have her. And Glenny, tell us a little bit about your background, what got you here, how you ended up with WatchPat, and let's dive in.
Absolutely. And thank you. First of all, thank you guys both so much for the invitation to be here. I love airway and dentistry, and combine the two together. We're in a great recipe for education here.
Absolutely.
So thank you. I was a dental assistant in a practice, and I was in the practice in Colorado, and we immediately dove into sleep and breathing and functional orthodontics. And this was probably in the year 2000. So, I mean, it's been a long time. It's been a long journey since I've been in there. When I was a dental assistant in the practice, we had WatchPat, and we had the very first version of WatchPat helping us the patients understand how they sleep and breathe. So I've got just a long history with them. And, just in my career of being, in a dental office, and then I also helped Dental Writer. I don't know if anybody's familiar with Nearman Practice Management. I worked for them for about 10 years, learning medical billing and helping offices understand all of that. And so I just kind of migrated over here to WatchPat. And our director, Joel Blixt, he invited me over to be on my amazing dental team. And so it's been about 2 years now that I've been educating specifically on WatchPat and teaching all over the country. And it's been a lot of fun.
Mm-hmm. Yeah, awesome. What makes WatchPat different than some of the other sleep studies out there?
Yeah, I mean, I actually have a cool little presentation if you guys want me to show this. I know some of you are just listening and can't see slides, but I wanted to kind of pop this up. I think the biggest thing about WatchPat that's different from any other device is that it's not airflow based. So pretty much every home sleep apnea test that's on the market is going to have some kind of cannula that goes up the nose, or an effort belt that goes onto the chest. And so what it's really measuring is how well or not well that patient is breathing during sleep. Well, why the WatchPat is different is that we are not measuring breathing. We're measuring, bottom line, the sympathetic nervous response, the activation that occurs, the cascade of events that happen when a patient stops breathing or when they have the respiratory effort related arousal. So a lot of the home sleep tests on the market right now, they have some limitations in that they're not going to be able to tell you true sleep time when the patient's awake or when they're asleep, what sleep stages the patient has, like how much percentage of deep sleep that patient's getting, or central sleep apnea. And if we can't determine those three things, then we're going to have a hard time understanding, if a patient has insomnia, or if sleeping on their back is worse than sleeping on their side, or if dreaming and REM related apnea is worse than regular, apnea, or apnea that occurs in non-REM. So these things I feel are super important, especially when you're looking from a structure or a dental perspective, because a lot of patients may not have apnea, but they have upper airway resistance syndrome, or they have a lot of arousals that are interrupting their sleep. So that's kind of the number one reason why I think WatchPat is so much more superior than a lot of the airflow-based home sleep tests out there.
Yeah, I agree, because a lot of people bring in their sleep studies to the dental office for us to look at, and it there's all this information, but it doesn't have the positional information. It doesn't show like in a clear, concise way, like what their sleep stages are and how many apneas or RDIs are happening during the REM when you're paralyzed and your muscles are frozen. So that's really, really interesting because I like to review sleep studies as well. And sometimes you'll see apneas during REM sleep, and then the rest of the sleep cycles, you won't see anything.
Exactly. That is exactly spot on. And so, I mean, think about this. If a patient's sleep breathing is worse during REM, when they're catatonic, when they're paralyzed, when they can't control that airway, then it really does lend to say oral appliance therapy or myofunctional therapy or working on the structure and the muscles could really play a good role, because if we lose the ability to use our muscles during REM, but yet we've been working them out during the day, or we have them in a better position with an oral appliance, then when we go into that relaxed position, our airway will remain open. And that is something that is so wonderful to see. So I think you're going to be so excited if you ever get a chance to really dive into a WatchPat report, because it's so clear. It's so crystal clear to show people what's going on. So really how the WatchPat works is, if a patient stops breathing, if they're dreaming or if they're sleeping and then all of a sudden their respiratory breathing just stops, they have a full sensation, whether it's for like a half a second or, 70 seconds. What happens is the body's fight or flight kicks off, and that activates the sympathetic nervous system. And what happens is the arteries in our fingers and our toes, they constrict. And really the blood flows to the heart and the brain because it's in oxidated stress and it wants to help. So it goes to the bigger organs. And so what the WatchPat is doing with that probe that goes onto the finger is it's recording that arterial constriction. And when we add that on top of the heart rate and the oxygen, we're able to tell with 96% accuracy, anywhere from 89 to 96% accuracy, what's really going on. And so we've been in over 600 studies against and looking at us with WatchPat, or I'm sorry, us with sleep test or PSGs. And so it's become, again, 89% accurate to PSG. So that's what's really awesome, I think, about the WatchPat.
What I think is cool too is just how like slim it is. Like it's, it's not so cumbersome, and you can actually like sleep with it on, which I think is really nice. Like, going to the hospital, patients always complain because they're like, well, I got this sleep study back, but like I didn't sleep the whole time I was there. So how is that even accurate to what's really going on? Like, it's really, really sleek. It's really, low. I don't even know what the word, interrupting.
Annoyance.
Like, annoying. I don't even know the word, but like, yeah, like it's not bad to sleep with.
You bring up such a great point, because I mean, even if you go to a hotel room, the first night is just like, whoa, you wake up the next day and you feel like you didn't sleep well, or you just maybe couldn't get comfortable with the pillow or the environment or whatever that is. So you just imagine going into a sleep lab and somebody's going to like physically there to watch you all night and hook you up to all kinds of different things. So many people experience not such a great experience going to a PSG. Whereas with the WatchPat, you're right. I mean, you wear it on your wrist, on your finger, on your chest, so it stays with you. So if you have to get up in the middle of the night, you just take it with you, and pretty much it's going to record everything you're doing.
Yeah. And I've done it twice. So the first time I did it, I was pregnant, if I remember correctly, with Isabel, because I wanted to make sure I wasn't having any like sleep apnea while I was pregnant, just in case I needed something extra. And then I did it just a few weeks ago with Glenny, actually. And I think when I was pregnant, I actually thought I was kind of uncomfortable, but I also had super insomnia when I was pregnant. And then when I did it again, I was like, oh, this is actually super easy. I don't even remember waking up much, despite what my sleep study says. Like, I don't remember waking up and not being able to sleep with it, which I think is really cool.
So did you see a big difference when you were pregnant versus not pregnant?
Yes, I had much more like arousals when I was pregnant. It was more of a UARS, on my back. And then this last time, I didn't end up on my back as much. I still had a couple of arousals, but I did get into, I think it was like 5 REM cycles, which was really cool.
That is very cool. I bring it up because I just know a lot of dentists that come across once, pregnant women come in, that they're totally fine before they're pregnant. They're fine after pregnancy, but it's during the pregnancy that they, have these issues. And so it's awesome because dentists can make temporary type of appliances that, and just monitor this temporarily. And that'll really help with the child developing in the womb as well. So it's an overall good thing, but it just brings up a good point, that your sleep is different in different stages of life. So if you're able to use something simple that you can wear at home, that you can barely even tell it's on, you're able to, get a good idea of what's going on different times in your life.
Yeah.
So like that. I think one of the cool things about the WatchPat is that, an office a dental office, a medical doctor's office, whoever's going to use them, they have 2 options. You've got the WatchPat 300, which is the one where you're going to lend it to the patient. Everything will record on the watch, and then it uploads into a computer system. And then you have our awesome WatchPat 1, which is my favorite. This is the one where you use a phone. It's an app on a phone, and
So cool.
It's going to record everything into the app. And then in the morning, you immediately have results. It's like a 15-second upload. So that's really cool because patients don't have to come back and bring the device. You don't have to clean it. You don't have to prepare it. Like it's ready to hand out, ready for patients to wear. And I think what I love about it is that if you have like 5 patients in one day that need a WatchPat, you can give out 5 in one day, because they're always sold in a case in 12. So I think that's been a godsend, especially with COVID. I mean, that's been such a big deal.
Mm-hmm.
All right. So walk us through what's the difference between the WatchPat and WatchPat 1?
Yeah, so that's a big deal. It's the difference is the WatchPat 300 is going to be something you lend to the patient, whereas the WatchPat 1, you'll use the app. There's really no difference in the information that's recording. That's all exactly the same. So it's just in the process of how it gets done. But what's really awesome is that you're going to get true sleep time. You're going to know if the patient has a central event, which is, kind of a big deal. Like we all focus in a dental office. We focus on obstructive sleep apnea, which is airway getting obstructed with anatomy. Patients can't breathe and it's causing arousals or full sensation of breathing. But there's also central sleep apnea, which just means that the brain fails to send the signal to the diaphragm to breathe. So the patient doesn't try to breathe. There's just no effort at all. And so with our central detection, we're able to tell, in the test, what type of apnea that patient's having. And we've been picking up on a ton of what's called Cheyne-Stokes respiration, which is a certain breathing pattern that a patient will develop when they're not making an effort to breathe. And so it's really important that we're able to look at that because we don't want to start treating patients with oral appliance therapy and never see their numbers change simply because their brain is just failing to send the signal to breathe. And so it's something that you can screen for. You can work with cardiologists and neurologists, in referring patients out when you do see central sleep apnea or Cheyne-Stokes respiration.
Dr. Zaghi in the Breathe course had an interesting point about central apnea and mouth breathing, because mouth breathing is a type of hyperventilation where you're breathing harder and heavier than you need to. So his theory was that mouth breathing can be a part of the whole central sleep apnea thing. It's like a protective mechanism almost for the body, so you don't get too much oxygenation, because then that's bad for you as well.
That is brilliant. And that's awesome. And that's all things that you can see with the WatchPat, which I'm sure is why Dr. Zaghi is such a big fan. I know he's been using it for so long. And a lot of people that go to his course use it. And I think it's just because of that. Exactly. You can see all of these things that you usually wouldn't see when you're just focused on airflow. And so that's one of my reasons why I love it. And, again, just to answer your question of the difference between WatchPat 300 and WatchPat 1 is that it's, the WatchPat 300 is battery operated, and so is the WatchPat 1, which makes it nice because you can turn it around right away. It's not something that you have to plug in and let it charge for 6 hours before you give it to someone else. It's just super, super simple and easy. And then, but the only thing is with that WatchPat 1, you may have, especially older patients that may not have, a smartphone, or they have trouble working apps and being able to sync all of that. So, so there's kind of when you just look at maybe an office has both, just depending on the scenario and what you're working with, with your patient. But I think, no matter what, one of my favorite things about the WatchPat is the CloudPAT portal, which is our online portal. I think I have a slide up here of it, but bottom line, it's where our clients go, where any office would go that would go into the portal to get it prepared for a patient. And what I love about it is that, we offer physicians that will interpret a study and give you a legal diagnosis and recommendation for therapy. But we've got, especially we've got this, awesome physician in Greeley, of all places, in Colorado. And he's starting to work with a lot of dental offices. So we have offices that are asking for him to be their interpreting physician, or dentists in California, that where Dr. Zaghi is boarded and licensed, they'll ask and request that Dr. Zaghi be added to their portal. So it's really cool because you can open it up on the back end to be able to work with local physicians and then choose, who your patients want to see for a diagnosis. And so I love it. I think it's a brilliant idea, especially for patients that do have upper air resistance syndrome. So they're not going to get insurance benefit for their therapy, but they want this awesome write-up about what it means and why it's important to treat. Dr. Zaghi's perfect for that, So, so I'm a big fan of having the CloudPAT at your fingertips to be able to do stuff like that as well.
Yeah, and all things considered, it's really not too expensive on the dental side of things. I don't want to give exact pricing in case that's not allowed right now, but for the dental office, we used to charge $300 was what our office charged, and that included the physician to read it and give the official diagnosis. So then that covered us on that side, but then the patient could also see okay, what are some steps I could do to start working on this?
Yes, exactly. And you're right on the nose. I mean, I definitely could talk cost. I mean, the WatchPat 300 is something that you would purchase and then you would buy disposables for it. So cost per test, it's probably cheapest on the WatchPat 300, depending on how many you do, because it's something you own and something that you're going to, just dispose of the pieces. Whereas the WatchPat 1, I mean, depending on the time of year, right now we have this awesome special where you can get 2 boxes at our government pricing. The VA and Kaiser are 2 huge clients that we have. And so we have a contract at our government pricing. And because of the AADSM meeting in May last month, we're able to extend it to the end of June. So, I mean, right now, WatchPat 1 can run you government pricing $85 up to our normal pricing, which is $99 per test. And then our interpretation fees are $65. So at $164 at the most is your out of pocket. So charging $300 is perfect because that, gives you your time or your doctor's time that you put into it, at least to pay for it. And it's keeping it at a low cost, because if your patients were to, go into a sleep lab or, maybe hire a service to offer them a home sleep test, they're going to be looking at $350 on up, in some cases, $1,200 or $2,400 for a PhD. So yeah, I think that's perfect pricing. And like you said, maybe it's just to get the patient's awareness up. Maybe they don't realize that their sleep airway and their sleep breathing is compromised at night. And this might be a perfect way to say, hey, let me show you, my director always says, use WatchPat like a mirror. Let me give you a mirror during your invisible time so we can see exactly what's going on. And then, we can decide on your next step from there. And so it's a great way to look at it.
Yeah, I love that. The mirror to your invisible time. I think that's so good. Well, and I think no matter what the, kind of pricing ranges, different offices, different charges, different cities, and we all can understand that, from a patient perspective, it's still very affordable. It's not pricing people out, it's not pricing our patients, it's not pricing our listeners out, to still get a lot of really, really good information. I mean, there's so much it looks at, and I just I think it's so beneficial.
And, I'm here in Colorado, and I came, for a couple of weeks, bring my dad and visit my mom here. And I got to go to a graduation party last weekend. And so I'm sitting there talking to people I haven't seen in 20 plus years. And we're talking about them and family members. And, of course, sleep keeps coming up. And
Oh yeah.
watching, how they talk. And I'm watching, just everything, physical appearance and teeth. And, it's everywhere. It's in every person I talk to, they had some kind of struggle with breathing or some kind of struggle with TMD pain or something was going on. And, it's just, I love WatchPat simply because when you're looking at only airflow and you don't know if a patient is asleep or not, you're going to have underdiagnosis. So if a patient were to go to sleep and they were to record, 8 hours, but they only slept for 5 hours and they had 100 events, 100 is going to be divided by 8 instead of 5. So it's going to say that the patient has less amount of events per hour. And so what's going to happen is that anybody that thinks that they have an issue, if they get to the point of getting tested and then the test says, oh, no, you're fine, your AHI is under 5, you don't have any problems, like you're fine.
Mm-hmm.
Then they just walk away thinking no big deal and they just blow it past. But if you were to actually see how much time they slept, divide it by the hours of events that occur, more people are going to have apnea and it's going to be more prevalent. And even patients where their AHI is less than 5, they still may need therapy. They still may need to be treated in some way. And so it kills me to know at this time and age of so many people that are struggling that, it could be prevented if we can look deeper, if we can look further than just the AHI number, if we can look at what's really going on with these patients. And I think in the dental setting, we have the best opportunity to have those conversations, to bring up that awareness, to kind of point the patient in the right direction, if you will.
Mm-hmm. That brings up a really good point, Glenny. Do you have any slides about upper airway resistance syndrome?
I don't have any slides, but here's what I'm going to do. I am just going to jump real quick into our CloudPAT portal, which is the portal that we go into to initialize tests and get everything ready. And I'm just going to pull up a random test just to kind of show you, because I have had the opportunity of teaching with some awesome sleep physicians. And, I've heard them talk about upper airway resistance and what they look at in a sleep test. And so I'm bringing up this one here. If we look here, this person, they started the test at 1, they ended it at 7, they recorded 6 hours and 21 minutes. We have 5 hours and 44 of actual sleep time. And if we look down, this patient had 28 respiratory effort related arousals. So, and this was throughout the entire night. So when you divided it by hours slept, it came out to be about 4.9 arousals per hour. And so if we look at 28 arousals, 11 of those arousals were actually apneic, meaning the patient stopped breathing for at least 10 seconds or longer with a reduction in their airflow. And so that actually only came out to be 1.9 per hour. So any physician that's looking at this would say this person does not have apnea. They would never have that. But if you look at the RDI is more than double the AHI number. So every time I've heard a physician explain it, they've said, if the patient's RDI is twice as much or greater than the AHI, then more than likely it's going to be upper airway resistance syndrome. And if we look at this, which is, almost 4 times, it's exactly 4 times greater almost. If we look over here, we have the RDI in REM, which is 9.4, AHI is 4.1. So for this person, when they're in REM, their airway, their AHI is 4 times worse, and their RDI is 6 times worse? So, or what would that be? 3 times worse?
3, a little bit more than 3.
Exactly. So this right here would scream to me upper airway resistance syndrome.
I like to think of the REM versus non-REM is the paralyzed muscles during REM sleep and the stiffening so you don't act out your dreams versus the just loosey goosey. I'm chilling, sleeping, everything's droopy.
Exactly. And so when you are tight and you're trying not, you're paralyzed, you're trying not to act out those dreams, you actually don't have control over your muscles to be tight. So it's in that deep sleep where it's going to be major loosey goosey, because it's like trying to pick up a child when they're in REM. They're just going to be dead, flopped out. And so, that's kind of how that airway works. And you can see that when you're looking, like in this case, if we identify the REM and you look up, you can see that this person's making more noise. Their heart rate is jumping up, that oxygen is dropping, they're making a little noise, and then they're having more respiratory events. And so, whereas when they're not in REM, in this case, there's some here, but you can see that the majority of REM versus non-REM, they're worse when they're in REM. And so, it just depends. But what's so great about the WatchPat is you can see it all just kind of right in front of you, to be able to explain that to the patient. So, yeah, that's kind of how I look at upper airway resistance syndrome. I have not ever seen Dr. Zoggy and how he explains it, but I'm assuming that he's going to be looking at those RDIs versus AHIs. He's going to be looking at REM versus non-REM. And, anytime we have an AHI under 5, but that RDI is greater than, more likely we're going to be seeing some upper airway resistance going on.
And Megan, correct me if I'm saying this incorrectly, but how I learned how to look for UARS would be you look at the RDI and it's similar parameters like AHI. So if 5 to 15 is mild, 15 to 30 is moderate, 30 plus is severe. Is that how you remember it too?
Yeah, that's how I've always understood it too.
Yep, that's exactly right.
Yeah,
That's it. So, with this person, if I were to sit down with this patient, any physician would tell them, oh, no, you're fine. You don't need any therapy. You don't have apnea. Everything is good. But I would have a serious conversation and figure out, what is your chief complaint? What are you struggling with? And more likely this person may say, I'm really sleepy. I'm tired during the day. And if you look, we can see that this person gets a good amount of deep sleep, but it's the interruptions in that deep sleep. And why are those interruptions occurring? Is it because of airway? Because we just realized, we discovered in 2019 that we get deep sleep to clean our brain. It's cleaning off beta amyloid protein. And so the more deep sleep we get, the better we do. And in this person's case, they get some really great deep sleep at 25%. But with the WatchPat, you may see somebody coming in with 5% deep sleep. And that's somebody we really got to work on to reduce the number of arousals so they can get into that deep sleep better.
Glenny, what is the recommended percentages of deep sleep, REM, light sleep? What would be like an ideal human's sleep pie?
Great question. I mean, if you were to Google just sleep architecture and just look at any photo showing you like a normal sleep architecture and what that would look like, ideally, we as an adult should be getting 5 90-minute cycles, somewhere between 4 and 5 90-minute cycles. And in the first 3 90-minute cycles, it should be heavy in deep sleep. And then the last 2 90-minute cycles should be heavy in REM. So I'm trying to pull up this quick image if I can find it in here somewhere. But if you Google it, you'll be able to see what I'm talking about. And so really, ideally, we should be getting about 50% light sleep and then 25 deep, 25 REM. That would be like the ideal scenario.
The perfect person.
But yeah, if you're looking at just kind of, what would be a ballpark, I would say, somewhere between 15 and 30% REM would be like an ideal, ballpark to shoot for. But I'd love to get 20 plus deep. So that gives us right at 25 and leaves us at 50% for light.
The interesting thing, going back to the UARS, is a lot of times if they get a PSG, it looks pretty normal, non-apneic, no snoring, and they're just kind of like, well, you don't have sleep apnea, so you're fine. But those people feel like garbage.
Straight
upper airway,
garbage.
yeah. Megan knows because she has upper airway resistance. I have apnea, but a lot of the upper airway resistance people, they're like kind of more on edge, a little bit more stressed, a little bit more busybody, high sympathetic nervous tone, more prone to headaches, more prone to clenching and grinding, more prone to like tension. They tend to be like more of those shoulders are up here and they're just tight. As well as just chronically tired, wanting to caffeinate, just tired.
Completely. And, we've seen that a lot with upper air resistance patients. And it's kind of like, just think of it as, if somebody were to come in and tap on your shoulder 20 times per hour, like while you're sleeping, like it's not that the airway is collapsing and that's what's, making you really tired. It's that the arousals, it's that it's not that you're waking up and you're looking at the clock and you're awake. It's like somebody's coming in and tapping on your shoulder going, hey, hey, hey. And like half the time you don't even know what's happening, but those interruptions is what's going to make you really grouchy, really tired, really high strung. And, it's like anybody. I mean, if somebody's tapping on your shoulder over and over, sometimes when somebody comes to tap on your shoulder, you're gonna be like, what? You're gonna jump and be like, oh my God, because you're constantly having that activation in your sympathetic drive. And so ideally we want to reduce the amount of arousals that are occurring. And arousal, it doesn't have to be a 10-second or longer with a drop in your oxygen and a reduction in your airflow. It could be a thing, that was like a half a second and boom, it's interrupted your sleep and you're not able to get to those deeper parts of sleep like we'd like to see.
Yeah, it still wakes you up. It still doesn't keep you in that REM, but it's, it almost very like, I don't even think this is the thing, but it's almost like new mom syndrome. Like you're always waking up to the baby. You're always, and then like you also like have to keep it together like while the baby's awake.
Of course.
And then like you're supposed to be like pleasant and, and I say this about like kids a lot too, like, we expect kids to still behave perfectly and follow the rules and, all of the stuff they're supposed to be doing. But if they're not sleeping and they're not getting into, that really good deep sleep that we need, why do we have those expectations when all of a sudden we're adults and you can say, oh, I didn't sleep good, excuse my behavior. And everyone's like, oh yeah, we get it. But yet kids, it's like, we don't care if you're sleeping like garbage. If you're not, following the rules or pay attention or you can't stop fidgeting, we're going to, label you as, behavior kid or a problem kid or test you for ADD, ADHD. And it's like, well, like, how tired are you, buddy? Like, what's going on? And that's, I think what I have found like a huge shift for me personally with treating patients lately is because I have seen a few of my quote unquote behavior kids just really become new kids once we get them sleeping good.
100%. I mean, I'm sure you guys have all seen the Finding Connor Deegan video. I mean, that that's what it's all about is, trying to get to the root cause. And a lot of times the root cause is just sleep. It's just getting better sleep, getting uninterrupted sleep. And, when we look at sleep hygiene, and we think about the ideal sleep stages, if the first 3 90-minute cycles are going to be heavy in deep sleep to clean our brain, but we as adults are too active during the day and we just have a really hard time trying to fall asleep till midnight or 1 a.m., then we're automatically depriving ourselves of the possibility of getting better deep sleep. So once we start to understand how everything plays a role and it all comes together, hopefully we'll become, more educated to know, hey, sleep is super important. And early sleep, getting deep sleep, that's a big deal. And then protecting our airway when it needs the most protection, which is in REM when our airway is collapsing the most, all of those things play a big role. So kudos to you guys, just really, carrying that torch and making and helping people become more aware. And then of course, spending your every day working on myofunctional therapy and really strengthening the muscles of the airway, that's such a big deal. And it's going to be such a big deal as kids grow and develop. So I'm so happy that you guys have dedicated your time for that.
Thank you, sweetheart.
Absolutely. But yeah, just kind of wrapping up my time with you. And again, thank you so much for having me. But, I've been just like you two, I've been an airway TMD pain patient pretty much my whole life. And, when I was 14, I can remember sitting in a dental orthodontic practice and, the orthodontist saying, we need to pull teeth to make everything nice and pretty. And I remember, looking at those awesome shiny white models and my mom thinking, pulling teeth, I don't know if we should pull teeth. I remember her struggling with the decision. And finally, we're like, okay, yeah, I mean, if that's what they want us to do, let's do it. We'll pull the teeth, we'll get it done. And I spent pretty much my whole high school, my whole college, just in severe, severe pain. And, if you were ever to see my x-rays, my condyles, my TMJ joints were literally in my ears. And, just so much pain. And so I, figured out a way in the dental practice to kind of relieve my pain by bringing my jaw down and forward, wearing orthotics forever, breaking orthotics, breaking night guards. And finally, with all my education, I just said, this isn't right. I shouldn't be in this position. So of course I got to meet Dr. Bill Hang, and we did upper and lower expansion. I got my bicuspid spaces back. And I think one of the major things that I realized in going through the expansion therapy is that he broke my habits. Like I was constantly like wanting to bite my nails or have like bite on a pencil or have some kind of like oral habit. And since I, started going through the expansion and getting my brackets put on, that went away. And of course, probably because I couldn't even bring my teeth together as I was moving everything around. But it broke my habit, and that I think has been huge for me because my shoulder pain, my neck pain, all of that, like you mentioned before with people with UARS, that constant on edge, that constant, your breathing is so fast, you have to think very fast, you're just always on the go. That all subsided, that all calmed down. And I'm so grateful for that. And, I'm still working on my bite and getting everything right. And I'm still going to collapse during REM in my sleep. I have the sleep test to show it and prove it, but I'm so much happier in a much better functioning position. So again, thank you guys for everything that you do. And thank you for having me on your show.
Absolutely. Glenny, go in and zoom on that. I want to see it. It's so gorgeous.
Yeah, we're definitely going to bring Glenny back to talk about her story, you guys, because she gave you little snippets, but it's really, really interesting. It's crazy to see all these changes, and like she said, her story is still going, but, just being able to breathe is just so huge. Like, it's so cheesy, but like breath really is life. And like, we see it every day and we can prove it. Like,
exactly. And so, yeah, I'm just showing my before and after picture here. You can see, I mean, it's definitely not the same exact picture. These were just, random pictures taken, but you could just see the shadows. You could see, the shadows around my mouth and how in depth my mouth was. I mean, you could just imagine it was pushed back at least 8 millimeters, the entire upper and lower jaw. And then my vertical, you can see like the distance between my head, my nose, and then my chin. It definitely wasn't a third. You can see that there was a discrepancy between my nose and my chin. So yeah, it was a journey in the upper and lower expansion, but definitely something I would do again. And I would recommend anyone that can do it. But I hate to have anybody do this. I'd rather you catch the awesome kids when they're growing and developing and help them to get to that second picture without pulling teeth and then having to reverse things, like just
having to undo it.
And that's where the tongue comes into play. That's where all the exercises, the habits, all of that. And if we can catch these little kids, if I could reverse back even before 14 and sitting in that orthodontic office, go all the way back and say, don't suck those fingers. Don't, get those in there. Don't develop those bad habits. That would be awesome. So again, that's all the work that you guys are doing. And so I'm so happy that you're out there doing that.
This is a beautiful photo too, because you look like a literal different person. Like, you're obviously a beautiful person, a beautiful soul, but your first picture, you look much older than the picture after your expansion because your bone structure is more developed. Everything came forward. Your eyes look bigger and brighter. It's like probably was cheaper than plastic surgery, right?
Exactly. And I tried to do everything I
And
could
more
to
effective.
line the pictures up because my face, my head, my face looks bigger in the second one. So I tried to do really good at lining them up to be where they are. But it is, I mean, just that whole oral system, it just came down and forward. And it just changed the whole position of my face. And if you look at it, it looks like my nose grew. My nasal arch, grew, which is, your palate is the base of your nose. So as you start to expand that, as you start to move that, everything's going to change. And that's what you're seeing.
So cool. I love it. I love it. So people who are interested in sleep tests, you guys, like, obviously you can't just like go like on the street corner and get them, talk with your doctor, talk with your myofunctional therapist, we can get you hooked up with a WatchPat, and really kind of start to see beyond like the one-dimensional piece of sleep, which is really cool.
Exactly. So yes, reach out to me if you guys need anything at all. I'll get you all my contact information. And again, thank you for having me on.
Yeah. And Glenny, how can people find you on social media? We'll put your email into the link for the episode too. But if somebody wanted to find you, how could they find you?
Yeah, so they can find me on Facebook. It's Glennine Varga Jerome, or Glennine Jerome Varga. I can't remember. But yeah, you should be able to find me. I think I'm the only Glennine. Glennine. And I think I do have an Insta account, but I'm one of those old school people that I haven't jumped into that yet. So that's the best place. You can also find me on LinkedIn. And, with working with Itamar, I'm constantly working with offices all the time. So my best thing is just reaching out, send me a text, send me an email, any of that works. So my direct line is 702-672-4490.
Perfect. I love it. And then of course you can find us, the Munch Bunch podcast, on YouTube, on Spotify, on Apple, all of your regular podcast, hosting sites. You can find Kimmy at Mouth Muscle Memory, and you can find me, Megan, at NWMFT on Instagram, on Facebook. We also respond to carrier pigeons if you got those out there. So we're pretty easy to track down.
Love it.
All right. Thank you so much, Glennine, and everybody else. Breathe through your nose.
Amen.